On this channel, we explore concepts in clinical reasoning in medicine in a simple and systematic way. Let's get started. Now we will continue our discussion about hyperglycemia treatment from the previous video. The diagram presents a stepwise algorithm for intensifying injectable therapy in the management of type 2 diabetes mellitus, when glycemic targets are not adequately achieved with oral medications and lifestyle modification alone. The flowchart emphasizes individualized treatment, prevention of therapeutic inertia, and careful titration of therapy to optimize glycemic control while minimizing adverse effects such as hypoglycemia and weight gain. The algorithm reflects current recommendations from modern diabetes management guidelines, including those from the American Diabetes Association, ADA. At the top of the diagram, the foundation of diabetes management remains reinforcement of behavioral interventions, including weight management, physical activity, healthy nutrition, and diabetes self-management, education, and support. DSMES. Patients are advised to receive regular reassessment every 3 to 6 months to evaluate treatment efficacy and adjust therapy when needed. This approach aims to avoid therapeutic inertia, which refers to failure to intensify treatment despite inadequate glycemic control. The algorithm begins when injectable therapy becomes necessary to achieve individualized glycemic goals. Before initiating insulin, the diagram recommends considering a GLP-1 receptor agonist, or dual GIP-GLP-1 receptor agonist, in most individuals. These agents are preferred because they effectively lower HbA1c, promote weight loss, and have lower risk of hypoglycemia compared with insulin therapy. Common examples include semaglutide, dulaglutide, and tirzepatide. The chart notes that appropriate initiation and gradual titration are important to improve tolerability, especially regarding gastrointestinal side effects. If glycemic control remains above target despite GLP-1 receptor agonist therapy, or if these medications are not appropriate or insulin is preferred, the next step involves adding basal insulin. Basal insulin is designed to control fasting blood glucose levels and provide steady insulin coverage throughout the day and night. Selection of basal insulin should consider patient-specific factors, such as cost, risk of hypoglycemia, lifestyle, and comorbidities. Continuous glucose monitoring, CGM, may also be considered to improve glucose assessment and treatment adjustment. The diagram recommends initiation of basal insulin using either long-acting basal insulin analogs or bedtime NPH insulin. Typical starting doses are 10 units per day, or approximately 0.1 to 0.2 units per kilogram per day. After initiation, insulin should be titrated gradually, according to fasting plasma glucose targets. One example shown in the chart is increasing the dose by approximately 2 units every 3 days until fasting glucose goals are achieved without causing hypoglycemia. If hypoglycemia occurs without a clear explanation, the basal insulin dose should generally be reduced by 10 to 20%. Regular reassessment is emphasized at every clinical visit to determine whether insulin therapy is adequate or whether additional treatment intensification is required. Signs suggesting the need for further therapy include persistent postprandial hyperglycemia, large glucose variability, elevated bedtime to morning glucose differences, or recurrent hypoglycemia. If glycemic targets remain unmet despite optimized basal insulin therapy, the algorithm recommends considering combination therapy with a GLP-1 receptor agonist if not already prescribed. Fixed ratio combinations of basal insulin and GLP-1 receptor agonists may also be used in selected patients to simplify treatment and improve adherence. When further intensification is needed, prandial insulin therapy is introduced. Prandial insulin primarily targets postprandial glucose excursions and is usually initiated before the largest meal of the day or the meal associated with the greatest postprandial glucose increase. The recommended starting dose is commonly 4 units per day, or approximately 10% of the basal insulin dose. Dose titration is then performed gradually, such as increasing by 1 to 2 units or 10 to 15% twice weekly, based on glucose monitoring results. Hypoglycemia management again requires dose reduction if unexplained low blood glucose occurs. For patients using bedtime NPH insulin, the chart suggests that conversion to a twice-daily NPH regimen may sometimes be necessary. One suggested approach involves administering approximately 80% of the current total bedtime dose, divided into 2/3 in the morning and 1/3 at bedtime, followed by individualized titration. If glycemic targets remain above goal after adding one prandial insulin injection, the algorithm proposes several intensification strategies. One option is stepwise addition of further prandial insulin injections before additional meals, eventually progressing to a full basal bolus regimen consisting of basal insulin combined with rapid-acting insulin before each meal. This approach provides the greatest flexibility in physiological insulin replacement, but also increases treatment complexity and hypoglycemia risk. Another alternative presented in the diagram is the use of self-mixed or split insulin regimens, where NPH and short or rapid-acting insulin are administered separately and adjusted independently. Pre-mixed insulin regimens administered twice daily are also an option for selected patients who may benefit from simpler dosing schedules. Pre-mixed insulin combines basal and prandial insulin components within a single injection, but offers less flexibility compared with basal bolus therapy. Throughout the algorithm, individualized care remains the central principle. Treatment decisions should consider patient preferences, risk of hypoglycemia, body weight, cardiovascular disease, kidney function, treatment burden, and ability to perform self-monitoring. The overall goal is to achieve effective glycemic control while minimizing complications, preserving quality of life, and reducing long-term microvascular and macrovascular complications associated with diabetes mellitus. As future healthcare professionals, hyperglycemia treatment teaches us a lesson that extends far beyond glucose numbers. Every elevated HbA1c, every medication adjustment, and every treatment decision represents a person who hopes to live longer, healthier, and with fewer complications. Modern diabetes care reminds us that medicine is not simply about lowering blood sugar. It is about protecting the heart from cardiovascular disease, preserving kidney function, supporting healthy weight loss, and improving quality of life. Behind every treatment algorithm is a patient whose future can be changed through thoughtful and compassionate care. As clinicians, our responsibility is not only to prescribe the right medication, but also to understand the individual sitting in front of us, their fears, challenges, goals, and circumstances. The best treatment plan is not always the most powerful drug, but the one that the patient can understand, accept, and sustain. Hyperglycemia management also teaches us the importance of lifelong learning. As medical science advances, new therapies continue to transform outcomes that were once difficult to achieve. What was considered impossible years ago may become standard care tomorrow. Most importantly, remember that every small improvement matters. A controlled glucose level, a prevented hospitalization, a preserved kidney function, or a delayed complication can mean more years of health and more precious moments with loved ones. In medicine, success is often measured not by dramatic interventions, but by consistent decisions that protect a patient's future. May we continue to practice with knowledge, humility, and compassion, always remembering that treating diabetes is not only about controlling disease, it is about empowering people to live better lives. Thank you for following this discussion. In clinical practice, what matters is not just what we know, but how we think. See you in the next discussion.